Good afternoon, everyone, and welcome to the Baldrige Foundation Institute for Performance Excellence Executive Roundtable. During the initial presentations, everyone will be kept on mute. If you have questions, please submit them to the moderator in the Q&A box located on your control screen. Presenters will answer questions during our panel discussion. Here are today's guests. Dr. Cynthia Barganier, Chief Operating Officer of the Institute for Healthcare Improvement. Carolyn Candiello, Vice President, Quality and Patient Safety, Greater Baltimore Medical Center. Dr. Larry Harrell, Professor, University of Alabama at Birmingham. And Dr. Jennifer Strahan, President and CEO, J. Osley and Company Incorporated. Now it is my privilege to turn the presentation over to our first panelist, Dr. Strahan. Jennifer?
Thank you, Al, and thank you to the foundation for allowing us to be here. And you can go ahead and change that slide, Jerry. You should see a poll pop up on your screen. We're just going to start as people are logging in. It's just a quick poll to see how active you guys are with us today. And as we go through today, we'll chat more about the different polls that will pop up. But in today's conversation, I'm going to try to summarize a year of research in about 10 minutes. I want to have ample time for interaction with our panel. So if I skip over certain details over the next few minutes, that's why. But I am happy to answer any additional questions as we move forward or even after the event if needed. So we'll take a quick look at our poll results in just a moment and we'll dive right in. Okay, good. We've got some curiosity and we've got people pumped up like Arnold. So this is good. We've got a few people awake, so that's perfect. We'll start, we're going to dive in. So as you likely know, the Baldrige program was established to boost competitiveness and performance of American businesses in the global economy, and subsequently to administer the National Quality Award to role model organizations that embody dynamics of excellence. However, achieving excellence can be elusive, and it requires extensive time, attention, and energy by organizations. In fact, some organizations report taking anywhere from 6 to 15 years to receive the Baldrige Award once they decide to pursue it, and some longer. So this could be one of the reasons the program has seen a diminishing number of applicants over the years, which you can see on the chart on your screen, which is broken down by industry. And the blue and green lines show the cumulative activity through 2018 by the 3 original industries and the 3 industries added later, respectively, healthcare being one of the industries that was added later around the 2000 year. So healthcare is the largest sector of applicants in Baldrige, and organizations that have received the Baldrige Award, the national award, say that there is significant value in the process of Baldrige, regardless of receiving the award or not. However, no studies have actually been able to understand or evaluate the pursuit of Baldrige. So the purpose of this study, this research that we did, was to understand if hospitals that applying the Baldrige framework as evidenced by applying for the national award, so not necessarily having to receive it, but incorporating both applicants and recipients, do they outperform hospitals that do not apply the Baldrige Excellence Framework? Next slide, please. So to answer the research question, we started with a literature review to verify self-reported outcomes with empirical outcomes. However, there were very few empirical healthcare studies that have actually been done, and results have been somewhat inconsistent. Patient satisfaction is one of the few measures that was consistently reported as a better outcome among Baldrige recipients. Process measures and core measures often reported mixed results depending on the study, and no studies have been able to confirm lower cost or better financial performance by Baldrige hospitals. And no one previously had studied the impact on market share. So one reason for the limited data, particularly around applicants, is because Baldrige submitted data are confidential until the hospital receives the award. So fortunately, we were able to partner with NIST to secure applicant data, which was maintained with the strictest confidence, and expand our research to include both recipients and applicants compared to non-applicants. So as I move forward and talk about the research, when I reference applicants, that incorporates recipients as well. So as we move to the next slide, you'll see another poll pop up on your screen. And I'm going to walk you through this. It's talking about your organizational attention. But we framed this study using attention theory. And I'll briefly highlight why that's important. Like individual attention, organizational attention is limited in its capacity, and it can be hijacked by competing interests, executive transitions, new markets, COVID, other things that obviously consistently pop up. Yet high-performing organizations are exceptional at being able to focus attention on the areas that combine top talent, passion, and financial potential. Attention theory suggests that variations, and if you just click on that slide, that should pop up. Attention theory suggests that variations in organizational performance are due to the level of attention devoted to different strategic priorities. So organizational strategy is therefore a direct reflection of your organizational attention, which is typically evidenced through the related actions and resources that you put towards those focused efforts. So obviously this is often directed by senior leaders in an organization. But based on that, organizations pursuing excellence, such as Baldrige, should see better operational, clinical, and financial performance according to attention theory, because their attention is focused on these things. So if we see those poll results, I'm curious to see where we land. So I love squirrel, yes. For those of you who are not familiar, that our attention, I think in healthcare, tends to be particularly sabotaged, often from everything going on. We'll talk more about these results shortly as well. In terms of our research design, we assigned hospitals into two groups. So we looked at Baldrige applicants, again, that included recipients, and non-applicants. And we used a propensity score match to identify 4 non-Baldrige hospitals for every 1 Baldrige hospital. So the goal of matching is to create like groups. We don't want to compare a hospital in New York City to a critical access hospital, so to speak. So hospitals were matched based on 7 characteristics. We looked at bed size, case mix index, system affiliation, profit status, being for-profit, nonprofit, and government, geography type, so rural and urban, as well as a micro division, which fits between the two, CEO turnover, and year. And descriptive statistics for each of those comparison groups did show that the groups were in fact similar. So in other words, the matching worked, and it greatly improved the likeness of those two groups. Assessed organizational performance across a broad range of variables to capture key elements of a typical hospital balance scorecard. So here you can see the specific variables that we studied. So we looked at operational measures, including measures of efficiency, such as average length of stay, as well as ED performance. And we looked at patient experience. Clinical outcomes included composite scores for mortality, readmissions, and patient safety, as well as CAUTI and CLABSI. We also looked at a variety of financial measures, which you can see on your screen. And another element we wanted to understand was market share. So does pursuing or receiving the Baldrige Award increase your competitive market share, which is represented in the Herfindahl-Hirschman Index, or HHI. So given we had a high number of dependent variables, again, we wanted that balanced scorecard, so it's about 20 variables, we were very conservative in our evaluation of results. So traditional research typically uses an alpha level or acceptable p-value of about 0.05 or 5%, yet we adopted a p-value of 0.005 or 0.5%. Next slide, please. For time, I will not overwhelm you with all the specific results and forms of regression that we did, but hopefully you'll be able to see that soon as the study is in its final stages of peer review. We found that Baldrige applicants and recipients demonstrated better operational outcomes, particularly around average length of stay and age caps. So specifically, Baldrige applicants and recipients reported a 9.1% lower average length of stay and a 1.43 and a 1.3 percentage points higher for HCAHPS, top box, and definitely recommend scores, respectively, compared to non-applicants. So there was no difference in other operational or clinical outcomes that we studied. So just to put this into context, if you were to quantify the impact of average length of stay based on studies from Kaiser Family Foundation, Advisory Board, you can extrapolate that 175-bed nonprofit hospital with average performance of admissions and average performance of length of stay, they would save up to about $15.7 million annually in just avoidable days compared to a non-Baldrige hospital without compromising clinical outcomes and while maintaining better patient satisfaction. So I think that's an important focus and lens to understand these different pieces. We did also analyze most of our financial outcomes along quantiles, but I'm going to simplify the results for the sake of time. And in terms of financial outcomes, Baldrige applicants experienced better results across 3 of the 8 measures, including return on net assets, days in accounts receivable, and expenses as a percent of revenue. Of all the measures analyzed, there was only one in which Baldrige applicants performed slightly worse than non-applicants, and that was days cash on hand of about 5 days. But from a practical standpoint, it's relatively small compared to the national average for days cash on hand of about 210 days. And we'll go to our final slide. So just to summarize, we generally found mixed results when we looked across the broad range of performance, favoring operational and financial outcomes. But let me just point out a few final considerations before we transition into our panel's discussion. So first, consistent with attention theory, one explanation for mixed results may relate to where the hospital's leadership team decides to focus its attention and resources. For example, administrators may focus on performance areas where they perceive more benefit, like length of stay, or in areas that we didn't even measure. This study did the relationship between Baldrige recipients and patient experience, but it also expanded that knowledge to include Baldrige applicants who outperform non-Baldrige hospitals in patient experience. Third, I would say attention theory also may account for the non-significant differences between Baldrige applicants and non-Baldrige applicants. So for example, every hospital in theory should be focused on improving clinical outcomes. So creating higher attention on those areas, which may reduce the differentiation between applicants and non-applicants in those areas. But remember, non-significant differences do not mean that Baldrige applicants performed worse than non-applicants. And finally, just keep in mind, we were unable to assess organizations that may have used different excellence frameworks like Lean Six Sigma or high reliability organizations or others. So those results in general are relatively conservative because those would be mixed into the non-Baldrige hospitals. So if I had to summarize the results in a sentence, I would say that applying the framework enables organizations to achieve better operational and financial results in select measures without negative consequences for clinical outcomes. So this should encourage more healthcare organizations to apply the framework regardless of applying for the awards program. But like most things, the Baldrige program is not a silver bullet, and it may not be enough to improve all areas of performance. However, that could just be a natural limitation of all hospitals or all improvement frameworks, considering the limits of attention. So regardless of the mixed findings overall suggest that hospitals should weigh the performance benefits against the cost of attention and time and resources to successfully implement that framework across the organization. So with that, I'm going to move into our panel discussion. And Carolyn, I'm going to start with you. You guys were one of the 2020 National Quality Award recipients. So congratulations. I know a lot goes into that. Behind the scenes. So tell us what drove your organization to launch Baldrige in the first place.
Great. Well, thank you, Jennifer, and some great and interesting research you've done. And we also thank the foundation for including us on this panel. You know, at GBMC in 2010, our organization started on our journey where we really began to redesign care, and we wanted to redesign it through the eyes of the patient. We redesigned our vision phrase and our vision statement. We summarized our vision phrase to every patient every time we'll provide the care we would want for our own loved one. And as part of that journey, we knew we needed to focus on quality, patient safety, performance excellence. We also knew that Baldrige was really, the state of the art, the best in class recognition of quality. It's, the nation's highest award for quality. And we made the commitment that this was something we wanted to pursue to show that our community, that this was a high performing organization providing value. As we began the journey, we realized that it really wasn't so much about the award, but it was the framework that helped us, begin to focus and align our priorities. And I like your example of the tension theory. There's an example in the Baldrige criteria of the arrows aligning and moving from that firefighting mode to really aligned strategic priorities. And that has really been for us the beauty of Baldrige.
That's perfect. Thank you. So Cynthia, in your daily interactions with hospitals, what are you finding? What's top of mind for executives right now?
Oh, thanks, Jennifer. And hello, everyone. Hello to my fellow panelists. Good to see you all again. And thank you all for this opportunity as well. What are organizations saying about their needs right now? So, there's a lot of conversation, obvious conversation about finances and costs and how organizations will kind of continue this journey toward cost reduction. But one of the things that I think has been refreshing as we've come as we're coming out of this is the number of organizations that have reached out to focus on their workforce. And it's not just about fleeing workforce or trying to the numbers of staff that they have, but they really are focused on staff well-being, really thinking about mental health challenges and the challenges around safety for workers. And I think that the COVID pandemic has certainly brought those things top of mind for leaders. And they also see this as an opportunity for attracting talent and retaining talent in this really challenging time. And a way of, also reducing costs, because they are challenged with the increases in the cost associated with staffing during a pandemic. The other thing that's been refreshing is a focus on quality and safety. And, I think that before the pandemic, we had started to see a little bit of a lull, particularly in my organization, around a focus on quality and safety. But now we are seeing more people reaching out for capability building within their organizations in order to build their own infrastructures and to be able to focus on quality with a focus on trust, not only from their staff, but from their communities around the levels of care that they provide within their organization and a consistency. And then lastly, I would say that, there is a focus on diversity and inclusion and equity, and more of a focus on equity, not just from the perspective of their internal organizations, those equity challenges internally, but focused on the community. And I think this also gets to this issue of trust and making sure that the community sees the investment and the attention of health systems and health organizations around the health of a community, not just the financial performance of an organization. So those are a few things. I'm sure CEOs would say there's a lot longer list out there.
That's perfect. And let's unpack a few of those, but I'm kind of curious, just listing out some of those basic elements of, finance costs, certain quality and safety measures. Carolyn, I want to come back to you for just a second. And I want to ask you around your journey to Baldrige. And I want to come back, I'll say this, I kind of want to separate out a piece of COVID and health equity. I want to have a deeper dialogue on that. So hold that piece if you will. But I want to know, what type of impact has Baldrige had for your organization in terms of we covered a few results in our research. Did you see any of those metrics move in your organization, or what other areas have you guys focused on to augment what Cynthia just said?
Yeah, no, that's great. And thank you, Cynthia. I think that does echo with what we're all feeling right now. And, one of the things we learned early on is, well, maybe not early on, maybe a third of the way into our journey, that Baldrige organizations are not perfect organizations. And, it is really not intended to you're not going to get perfect in every single outcome. You get results based on what is important to your organization and your community. Some of the things that we have seen some really remarkable improvement, I'll build on some of the things Cynthia shared, talking about workforce injury. We started this journey, we were having about 1 injury a day to our workforce. And, that's not what anyone wants, because it doesn't just affect your daily work, it affects every part of your life. Using some of the tools that we use within the Baldrige framework, we're now at less than maybe 4 to 5 a month. So it has made some terrific improvement and really measurable impact on our workforce. Obviously we've seen reduction in harm. That has been our focus. Every day we look at measures of incident of patient harm. And, these are things such as, hospital-acquired infections, surgical site infections. These are things where we are performing, better than expected in many of these areas. Even in finance and other areas, for example, our cash to debt total ratio, we have really strong numbers there. We're performing better than our competitors. And, it's through the use of the Baldrige criteria that we're able to sustain that and to continue to drive value for our community.
That's great. So Larry, I want to come to you because I want to bring in the research arm of this. And obviously, for those of you who are not familiar, but Larry was one of the co-authors and supporters with the research that we did. And his career has been focused on a lot around organizational performance for hospitals and networks and others. But I want to talk about right now, we're in some ways a novel time, and I think we're getting through it and doing well, but it also creates a really significant opportunity to create partnerships between hospitals and practice and research. And I'm curious, based on the research we've shared earlier and thinking about what around Baldrige and just excellence in general, how do we better understand the science behind Baldrige, and what would we need to do to kind of make that take the next step?
Well, it's a great question, Jennifer. And well, first, let me start by thanking you for asking me to join the panel. Happy to be here and learn more, I think, from all of you, more so than what I've already learned from you as you went on your dissertation journey, a different journey of sorts. No, I think when thinking about trying to understand, I think, the science behind Baldrige, one of the things I think it's going to require to really kind of move the field forward and to understand the science is more kind of collaboration and partnerships between researchers and practitioners, because as researchers, we have our own sort of approaches, I guess, or in some ways limited means of really trying to understand what Baldrige looks like on the ground, so to speak, and what healthcare organizations do when actually pursuing Baldrige. In other words, if given a data set, we can sort of see at a high level the different components of Baldrige, but really understanding kind of the challenges that healthcare organizations face when trying to pursue Baldrige, and what seems to be effective when trying to pursue Baldrige. That really entails getting inside of organizations and talking to people and getting access to data that, as researchers, we oftentimes do not have. And again, that entails a partnership, and it's challenging. I mean, I think there's a lot of interest these days in trying to foster partnerships between academics as researchers and practitioners. But the reality is that we have, again, sort of different priorities in what we emphasize. So researchers will oftentimes come into this with a very kind of mindset of what's the most rigorous study we can do to understand whether Baldrige is effective. Well, to establish rigor takes a lot of work. It takes a lot of data collection. It takes a long time. And that may not be the priorities of practitioners. Yes, you want to know whether it works, but you want to know whether it works quickly so you can make a decision about how to move on. So, kind of navigating those partnerships in a way that you have clear expectations up front, I think, is imperative and one of the biggest challenges. But I do think that is really one of the key things we'll need to think about as we think about how to continue to really understand what makes Baldrige tick and what makes it effective.
Yeah. So Cynthia, let me come back to you, because thinking about priorities, thinking about just excellence in general, whether it's an organization that's on a Baldrige journey, or maybe they're using IHI, or again, all the different mechanisms that we know that have a very similar foundation, but kind of different flavors, if you will. What are you seeing? Are organizations slowing down because of COVID? Are they picking up the pace? What are you starting to see in terms of organizations and the pace of their excellence journeys?
Well, I think that people are struggling with the concept of priority and trying to make sure that we can focus efforts on a few things and not everything. And I think one of the challenges is that there are so many opportunities for improvement within the health system. Trying to identify the 3 things, for example, that you're going to focus your attention on, I think is one of the biggest challenges that people are having. We have those challenges even internally within our own organizations. So you can imagine. So I think that is, trying to narrow and figure out where the biggest impact will be on from a quality and safety perspective, and from an outcomes perspective, and then trying to translate those outcomes into the leading indicators that are going to help your staff to really see their work in those outcomes, whether they're process indicators or whatever, so that they see them, that they are demonstrating work toward those improvements, I think is really important. And keeping people's eye focused on those things and their work focused on those things. It's a challenge, but it is a way of kind of keeping people centered and aligned.
Yeah, I completely agree. So this is probably a perfect time, Jerry, if you don't mind launching, we have a poll for the audience to ask you guys about your strategic priorities, because I think pre-COVID as hospitals, we were not very good about creating priorities and actually saying no to things. And then of course, with COVID, I think it was probably one of the best times we said no to things for a while, because we had no choice but to focus on COVID, but now organizations are being thrown beyond that. There's so many other factors. So I'll give you time to read through that question as it pops up on your screen. But Carolyn, I want to ask you, so this is when I want to come back. How did Baldrige help you not only manage your strategic priorities, but especially when something like COVID did come in, something completely unexpected that really threw your strategy out the window to some extent? How did it help you to focus on things like COVID and also other efforts that have continued to come up around diversity, equity, inclusion, health equity, other factors? How does it help you in that process?
Yeah, that's, really, when COVID emerged, we were in the middle of 2 processes. One, working on our application for the 2020 award, but we were also in the midst of our strategic planning process. And I'll, talk a little bit more about that later. But I think the strategic planning process, we recognize that many of our critical systems within the Baldrige framework were essential for us in responding to this crisis. And, using that critical systems approach, we have about 33 critical systems that align through all 6 categories. We were able to use those along with our core competency, which is redesigning care, to really redesign how we approached our patients, how we approached our workforce, how we approached our community. I'll give you an example, our communications process. We had to rethink how were we going to engage in two-way dialogue with our workforce and with our community. We were able to, move to this kind of platform like most organizations and begin to measure, are we getting the engagement of our workforce? Are we answering their questions? That was one process. Our capability and capacity process in category 5. We needed to very quickly retrain nurses who were in the surgical care setting, and utilizing like our sim lab. We were training them how to work at the bedside, in a critical care setting. We redesigned some of our staff to address our supply chain priorities. So, as most organizations, we couldn't get shields and masks, so we had staff trained to build masks. So, I think because we had these systems in place, we had owners of these systems, we were able to apply those to COVID, and I think it really helped us respond more effectively.
Oh, go ahead.
No, I was just going to say, in answer to your other question, but I can pause there too. Of how do we continue to use that to address things such as diversity, equity, and inclusion. Is that where you were going, Jennifer?
Yeah.
Okay. So our strategic planning process, it is really core. I think it's one of the most important. I think all of the categories are important, but I think about the strategic planning process of really getting your processes aligned and integrated is so important. And so part of our strategic planning process is this annual environmental analysis. And so we all participate in various things. We listen to our community, we listen to what's going on in industry through the IHI, for example. And, we identify that, structural racism really has an impact on health outcomes and quality of care. And, in fact, in Baltimore, for example, depending on which side of York Road you live on, which is kind of a dividing line in Baltimore, there can be as much as a 12-year difference in mortality. And so we're now adding that to our strategy. It's something we feel is important as we, again, coming back to our requirements of our community. What does it look like? We're increasing access and reaching out, getting proximate to those communities that are underserved.
That's great. And so, Cynthia, obviously you've been in Chicago, and I can't remember the study, but I do remember reading something a while back ago that talked about the life expectancy on the L and kind of the differentiation, how it drove variation just in the city of Chicago as well. And I also know with IHI, you guys are doing a lot of work right now around health equity and partnering with organizations. So talk to us a little bit about what you guys are doing, how are hospitals integrating that into their strategy? What are you seeing as drivers behind that?
Well, I think that a lot of organizations are looking outwardly to look at the communities that they serve, as Carolyn pointed out, and looking to see where the opportunity is for improvement. One of the things that I think, you're right, there was a study that was done that looked at the Chicago land area and, taking the train from the Gold Coast, which is one of the more affluent areas in the country, actually, but certainly in Chicago, out to Austin, which is probably about a 10-mile L ride, is there is about a 20-year gap in mortality and life expectancy. But one of the things that recognizing that this neighborhood is in our backyard and was in Rush's backyard, I still call them our, and recognizing that even though this community is in the backyard of the organization, as one organization cannot change, make the kind of change that is necessary. So they did create an alliance within the city of willing partners to help to look at not only health outcomes, but recognizing the social determinants of those health outcomes and really looking at economic vitality in these neighborhoods, food security, housing security, and all the things that impact the health of a community, and really taking a holistic approach to how the organization would engage the community. And I think that is the approach, and it's the approach that IHI has also taken. But I will say that as an organization, you also have to address some of the systemic issues that may be driving disparities even within your own organization, and not just focusing, because they used to say at Rush, they look at the zip codes. And so you're looking at 8 zip codes, well, the 9th zip code is the zip code within your organization. So many of your employees come from the communities that you serve. And many of your employees are dealing with some of the same issues that you are trying to address within these communities. And so not forgetting internally that you have stewardship for the employees within your organization. And then finally, really looking at some of the causes of systemic racism that are driving some of these inequities, even internally within your organization, and getting very introspective about how you might have to make changes even within your organization in order to make the change that you want to see. So those are a few.
Yeah, that's perfect. And some of you may recall, even when COVID was relatively early, we had hosted a series of learning labs that brought together hospitals and communities, because it forced, I know we've talked about population health, we've talked about social determinants for decades, but it kind of forced people into that world if they had been a little bit more on the outskirts. And so it's interesting to watch some of those dynamics come together, and we can talk more about that in another time, because I think that could be a whole more than obviously an event, but certainly days and so on that we talk more about that. But you addressed some of the things around systemic issues. And so Larry, I want to come to you again, kind of pulling in some of the research side of this and looking at the current state of not only just the environment, but quality improvement in general, and understanding, what are some of those high priority needs for researchers and practitioners to consider?
Yeah, sure. Well, I think thinking about the research anyways, but even from a practitioner standpoint, I think we've done a relatively good job of understanding whether and how isolated programs can affect quality. If you think about it, hospitals may pursue a particular QI program, and as researchers, either partnering with health systems or even just internally doing the evaluation on that. Again, the evidence there, I think, is pretty good to understand what types of programs can improve quality. Good examples of this are things like care transition programs, infection control programs. We know that, at least in some cases, what those programs look like and whether they can improve quality. I think one of the big gaps in our knowledge, however, exists with respect to how the lessons learned from these isolated programs can be, in a sense, institutionalized into healthcare delivery organizations to build capacity to continue to improve quality. I think Cynthia and Carolyn have both referenced this idea of building capacity within the organization, and I think that in a sense entails taking a step back from these individualized programs and thinking about, well, how do we leverage this? How do we sort of build on this to in a sense build a system that can learn from these experiences and apply them to other ones moving forward. And that's just something that we don't really know a lot about. So for example, what kinds of institutional supports are needed to kind of build that capacity? What are the most effective organizational structures that you can use to kind of support that capacity to learn and apply lessons from other projects to future projects? And answers, I think, to those questions are imperative for meeting the needs of a growing number of patients with complex comorbid conditions, because I think as researchers, we're guilty of this as well. Let's just isolate only on patients with diabetes and see whether this program can actually improve outcomes, lower the HbA1cs and so forth. But we know that patients with diabetes also have a lot of other conditions, and there's a growing number of comorbidities, and it's going to take programs that can kind of address those comorbid conditions. And that's the idea that we're going to isolate one particular program, I don't think is going to be enough moving forward. So I think that's one of the big areas. I think another one, given kind of the growth and expansion strategies of hospitals, I think there's a need to extend some of the QI work beyond inpatient settings. I think they have to date received the bulk of the attention, and maybe for good reasons, but the challenges, I think, of engaging in QI in different settings, like primary care settings, I think looks a little different, and a better understanding of those differences could help us as both researchers and practitioners understand how to best overcome some of those challenges.
Yeah, that's Cynthia. Did you want to add something to that?
I just wanted to put a +1 to Larry's point around the continuum. And the continuum is becoming more and more active from a patient care perspective, and particularly hospital at home, in addition to some of our more traditional non-hospital based care delivery models. And I think that if we're going to not just shift patients from one setting to another, one inefficient setting to another inefficient setting, we're going to have to really be aggressive about applying these improvement principles, the patient safety principles in those settings as well as acute care hospitals. So just to +1 your point, Larry.
Yeah, I completely agree. One of the things that's really interesting, so you brought up, there's a lot to kind of unpack in what you just mentioned, but one around going into individualized programs and then looking systematically, which goes into some of those bigger processes and problems we're talking about in the general environment around equity and such, and understanding the systematic nuances of things. Carolyn, coming to you, when we think about Baldrige, one of the things that I think is a blessing and a curse is that it is systematic, but it can also be a little overwhelming sometimes for newer organizations to assess. And let me also just mention, so we had out of our 60 individuals that were registered for today, we sent out a survey to everyone in advance, and about a third were able to respond. And out of those, we saw half of the people who did respond have not started their Baldrige journey yet. And then almost the full other half were early in their process. So granted, not everyone responded, but that, again, pretty good size sample of what we look at. And one of the common things we hear from people as well, it's complicated because it is systematic. It doesn't necessarily leave a stone unturned in that process. So how did you guys break down that complexity and really engage people in that process without overwhelming them?
Yeah, well, I think it's a pretty deep question because, I could probably talk about it for quite some time. And I think one of the things I would advise organizations, and someone said this to us early on, is, just start anywhere. And I think that's good advice. But I think the thing that was really helpful for us, and I would say, don't try to do this alone. There are so many other organizations that are out there and are on the Baldrige journey, find those other like-minded organizations. You know, the spirit of the IHI, which I just love, is all teach, all learn. And that has been our mantra. And I think you will find that in the Baldrige community. And whether it is, you know, attending, you know, the Quest conferences, which we started doing early on, attending share days, reaching out to other award recipients, you know, those things I think really help strengthen you and realize that you really just need to get started. And one of the other things that was pivotal for us was we did a share day, and a number of our key leaders attended. And when, you know, for example, COO to COO were able to connect and see the value of Baldrige through a shared lens, I think that really began to help us formulate and put things together, and the dots started connecting. And we didn't tell the organization we're doing Baldrige. We just said we're doing performance improvement, and that was our approach for quite some time. And in fact, when we got to the time of a site visit, we really had to do a little education about what this was all about. But you know, I think it's reach out. You know, those of us who are on the journey are always willing to help another organization.
So that's, I think, very telling. And Larry, I want to come to you because you've done a lot of work with networks, and I want to kind of your impact and understanding on what do we know and what do we not know about network approaches to learning, if you will. I believe in healthcare, it's one of the industries that we do more networking than most any other industry because we do like to learn together. So what are some of the things that you've been able to observe in your research and also in challenges that hospitals may face?
Yeah, it's a really good question. Again, I think, you know, part of the answer is depends on how you define networked approaches. Sounds like an academic answer, but, you know, I think we know a lot about how things like multi-hospital systems work together towards shared goals. So that's one way of thinking about networks. And there is a pretty robust literature that is focused on multi-hospital systems as these kinds of networks. Unfortunately, we know a lot less, however, about more informal networks and how they work together towards a shared goal. And in part, from a research perspective, these informal networks, as I think about them, they're hard to identify and consequently somewhat hard to study. Nevertheless, I think there is some literature outside of kind of hospital settings that does help us understand the primary challenges that hospitals might face when trying to leverage these kinds of networked approaches. And a lot of this draws upon, Cynthia, you mentioned these alliances or community coalitions, and that's where a lot of what we do know comes from, and where these very and somewhat disparate organizations come together for a common goal of improving health in a local community, you know, broadly speaking. But from that literature, one of the things we know is that first and foremost, one of the challenges is agreeing on a common goal. You know, this might be more straightforward with a network of hospitals pursuing Baldrige, but it is deceptively difficult when priorities differ or there are situations where it's perceived as a zero-sum game. And even though healthcare is different, and I agree with you, Jennifer, on that, there is still a part of that zero-sum game kind of competitive mentality that is still underlying, I think, a lot of how organizations interact. And second, related to the first, is this issue of attention, which I know guided your dissertation and has been a part of the discussion here. Healthcare organizations and hospitals in particular, you know, when you think about it locally, they tend to be enmeshed in these complex web of competitive and cooperative relationships. You know, they're competing in certain areas, collaborating in other areas. And I think And one of the things we've seen is that too often these organizations will choose to collaborate on issues that are convenient but they're not necessarily strategic imperatives, right? It's easy to kind of collaborate on these low-hanging fruit, but the harder issues do not necessarily get the attention and the resources they deserve. And consequently, they tend to, they're sort of left to wither on the vine. And I think those are at least some of the bigger challenges that we've observed when we've studied these alliances and these coalitions or these more informal networks. It is really kind of common goal setting and just really kind of getting the attention of these organizations that are participating and making sure that they make whatever that common goal is a real strategic priority for the organization so that they can put the resources behind it.
That's interesting. It's one of those things that when you hear it, it's not earth shattering, but yet somehow we're not very good at it when we look at it. So I'm going to have, Jerry, if you don't mind, we're going to launch that last poll because I think it's a good time to understand when you're, to Carolyn's point, I love how you said it, don't do this alone in your process. And I do want to take a moment to talk about the learnings that we have from our research. And so also while you have that, if you don't mind, Jerry, going back to that next slide, I just want to take just a moment to introduce to the audience what we're going to be doing. So while that's coming up, I'll just mention that speaking of, learning and networking and anytime we complete research, we should always really look at how our learnings translate into practice. So we've talked a lot about concepts related to Baldrige, and we're not done yet. I do have a couple other questions, targeted questions. I really want to get our panel to some actionable takeaways for you guys. But I want to take a moment to just share with you how the Baldrige Foundation and Jay Owsley, we want to use this research to really bring value back to hospitals. And even though Baldrige has been around since the late 80s, as with any sustainable solution, we have to start thinking about that evolution of Baldrige. And I think one of the most encouraging learnings from the research is that the value of Baldrige really expands beyond just the select few who receive the national award, but actually benefits applicants as well. And in fact, our research actually showed little to no difference between Baldrige recipients and applicants in terms of most of the objective measures we studied. So as I mentioned at the very beginning of our session, Baldrige is aimed to really support and boost overall performance, but we miss a key opportunity for growth because most Baldrige organizations are doing it alone. They journey alone. And we want to change that. We believe that there's really an opportunity to maximize value and create larger differentials for Baldrige hospitals by creating a learning network to bring together shared knowledge, but also targeted and actionable implementation and more real-time research and learnings because there are so few empirical studies out there today. So if you just could go to the next slide for a moment, we're excited to be able to introduce a collaborative network to you. So a meeting of the minds, if you will, and our minds here being around measurable improvement network and diffusion scholars. And we aim to kick this off this fall. Our target is October. And it's intentional there in terms of we want to really create impact or measurable improvement, as well as look at diffusion of research and learnings. And so we just want to introduce you to this today. We're not going to get into detail of it, and we can follow up with anyone who might be interested, but just a few highlights I'll point out here. During this network, you can really maintain your individualized excellence journey. So at the same time, we want you to be able to partner with faculty to implement targeted improvements in ROI with your team that do align back to your strategic priorities and your attention, so to speak, as an organization. At the same time, we're incorporating ROI tracking across the network. So there's a shared dashboard for key metrics, including, for instance, some of the ones we covered in our research to really, again, be able to study those a bit more, as well as areas such as employee engagement, which has been a metric commonly referenced by organizations on their Baldrige journey. But because of the inconsistencies in data capture, it's one we couldn't study in our research. As well as understanding and building relationships with mature mentors and organizations that might be more at your pace, whether that's starting out or you've been on the journey for a while. And then finally, really driving new research that can be shared across the industry, again, but first within the network, so there's benefit there. But what's unique is just being able to integrate learning, implementation, and research. And there's a lot more to this, and that we will talk about. Again, we can talk about it another time, but we're really aiming to keep the cost down. So we're seeking grant funds right now to subsidize network participation for small and rural facilities. So if that's relevant for you, keep that in mind. And I'll also just point out 2 other quick things. One, this is not just for Baldrige. So if you're on an excellence journey, and it may not be, to Carolyn's point, many organizations that initiate Baldrige don't start by saying, we're kicking off Baldrige. They just have their self-branded excellence journey, although we will emphasize and focus on Baldrige concepts at the core. And so it also doesn't compete if you have a Baldrige consultant you're partnering with. It only enhances that experience. So whether you're on day 1 or if you've received the national award, it's applicable for everyone. We really just want to learn together and make progress together. So with that, I want to just use the last couple of minutes to make this very tangible for you guys. We've talked about a lot, and Jerry, you can take those down now if you don't mind. But we've talked about a lot around shifting the tides of hospital performance and really looking at, is there a competitive advantage behind Baldrige and behind just excellence in general. But in rapid fire fashion, I want to go to each of you guys to see, if you had to bullet 1 or 2 takeaways, again, actionable takeaways that attendees could go out and start to think about or implement tomorrow, what would they be? And Larry, I'm going to start with you, and then I'll circle back around to Carolyn and Cynthia.
Sure. Unfortunately, I'm not sure I have the tangible takeaways as a researcher, Jennifer, but I'll leave that to Cynthia and Carolyn, who I think can speak to those. But as far as the takeaways that I have, I think they center around 2 words: journey and partnerships, right? I've heard that throughout today's panel or today's discussion. And, I think on one hand, that's encouraging in the sense that I do think those are areas that researchers are starting to take closer attention to. As we know, research tends to lag practice, despite what we would like to believe that it goes the other way, that we're making evidence-based decisions based on well-established research. The reality is that the opposite is often the case. But I do think there is a lot of growing attention on these issues of partnerships as well as process, rather than, I think, inherently a lot of research is focused on kind of structural, stable attributes. And the idea of journey and process, I think, is something that I've heard a lot today. And I think there's a lot more researchers paying attention to that. The bad news, again, I think, is just that there's a lot more that we have to learn about those things. And I think that's going to require, in some ways, a bit of a paradigm shift, particularly for researchers, and thinking about how we better partner with practitioners to start to provide that evidence base to really unpack some of these performance excellence frameworks like Baldrige that we're talking about.
All right, thank you. Cynthia, can I come to you next?
Sure. I think that one of the key takeaways for me is really focusing on performance improvement from a strategic perspective, and recognizing that this is a way of elevating quality of care that we deliver within hospitals and health systems and across the care continuum. But that is the pathway to value and reduce costs. And that those 2 things don't have to be separate, and that we can think of them strategically and aligning our goals and approach around that. I think the other thing that was, I thought that Carolyn said, there were 2 things that Carolyn said: start somewhere, because, it is so easy to become paralyzed by what seems so big that you just don't know where to start. And I love the start somewhere, simple advice. And also, I love the point about don't go it alone. And I think that kind of harkens to Larry's point that there are partners and there are partnerships that you can create to learn together and not try and do all of this on your own. And then I think the last piece, I think, is really building capacity and creating a learning environment, creating a learning culture within your organization will create the hunger from all of your staff for improvement and looking for ways to elevate the quality and safety of the care that they deliver, the providers deliver. So
Yeah, that's perfect. That's great. Thanks, Cynthia. So Carolyn, I want to just be able to get a moment from you as well and hear your learnings.
There's a concept I learned again at IHI is, what are you going to do by next Tuesday? And I encourage you, if you are listening to this call, make a commitment to do something by next Tuesday, even if it is talking to someone else about what you learned today, and that will really help get you started. More practically, I say identify 2 or 3 people on your senior team who you can enroll in this process. While it is necessary to get the organization involved, this really requires, I think, top-down commitment to get it done. Top-down doesn't mean top-down does the work, but you've really got to set the priority that this is important for our organization. And assign category leads, have those category leads begin to pull together groups and say, let's answer these questions. And how do we do things? If you can't map out a process for how do you lead at your organization, then you don't have a process. So think about what is your process for all of these things. And these are things we learned on our journey. And don't be afraid to look at other applications. And we thought early on, oh, I don't want to steal from this one. But that's the whole intent of Baldrige is learning from other organizations. And you can see leadership systems across all of the applicants, and they're all a little similar, but unique to each organization. As Cynthia said, that learning organization, we wanted to get a lot of folks trained as examiners. I think that can help build that capacity. And just set that goal to submit an application to your state organization if you haven't done so. Writing that first application is hard, but it's really worth it. And our first one, it really was terrible, but it was that first step, and we just kept building on it. So reach out. We're here to support you, and I know other award recipients are as well.
That's perfect. Thank you so much, Carolyn. And Al, we're going to turn it back over to you.
Well, Cynthia, Carolyn, Larry, and Jennifer, thank you so much for today's presentations and engaging conversation. As a reminder to the audience, for those of you who submitted questions we were unable to get to, you can expect to receive a written response from the presenters sometime in the next week. If you would like to review this webinar, it will be posted to the Institute for Performance Excellence website in the next 48 hours. Once again, thank you for tuning in today to the Baldrige Foundation's Institute for Performance Excellence special webinar, Shifting the Tides of Hospital Performance. Can Baldrige give you a competitive advantage? Thank you very much for your attendance, and have a great day.